You reached for that prescription bottle this morning without hesitation. Same motion you've performed every single day since that first appointment. 8 seconds, maybe less. But if you're over 60 and that medication is Amlodipine, Losartan, or Lisinopril, something is occurring inside your physiology right now that your doctor likely never fully discussed with you on the way out of that visit. There was a woman named Ellen, 72, a retired librarian from Kansas City, extremely organized about her well-being. She'd been taking Amlodipine consistently for 18 months without missing. Her son reached out to my office one Wednesday morning, concern evident in his voice. He mentioned his mother had canceled multiple social gatherings recently, stopped her volunteer commitments at the local literacy center, and refused to wear anything but loose slippers because swelling in her lower extremities had become so severe she barely recognized her own legs. Ellen believed her cardiac system was deteriorating. She'd already begun writing farewell correspondence to her grandchildren. That letter was unnecessary, but the absence of clear explanation about what was genuinely happening nearly cost Ellen precious months. I'm Dr. William Lee, a heart specialist with more than a quarter-century of clinical cardiology experience. What I'm walking you through today are 9 absolutely essential facts every older adult taking any of these 3 medications should comprehend. Not because your physician intentionally concealed details, but because a typical office visit provides roughly 12 minutes for something requiring substantially more time. Before continuing, I need something from you. Share your age in the comments right now and tell me this honestly. Since beginning your pressure medication, have you experienced anything you quietly attributed to aging itself? Write it down. What you share might be the exact concern someone else has silently worried about mentioning. Everything we're discussing today, understanding these specific medications and their effects, represents exactly what my patients bring up during nearly every appointment. I've assembled all the guidance I share with patients into a comprehensive resource called the After 60 Protocol, Live Longer and Stronger Past 60. It covers 28 significant health shifts that accompany aging, including your cardiovascular function, metabolic health, cognitive performance, and physical stability. Thousands are already utilizing it to take command of their wellness, and I've seen it genuinely transform how people experience their later decades. You'll find the link in the description and pinned at the top whenever you're ready to explore it further. Now let's continue. If you're seeking comprehensive, straightforward health information instead of rushed appointments, subscribe immediately. Each week, I provide direct answers about your physiology, not simply prescription refills and rescheduled visits. Here's the typical pattern. You sit in the doctor's examination room. The conversation concludes quickly. 2 words are mentioned: elevated blood pressure. A prescription follows. Take once daily, return in 12 weeks. No clarification about what transforms within your blood vessels after that pill dissolves. No discussion about how a 72-year-old body responds differently than a 45-year-old body to identical medication. Simply an instruction and a bottle. You leave believing something incomplete, that the medication solves the problem. The actual situation is more detailed. There are 9 essential understandings I need you to have before consuming your subsequent dose. The 9th addresses something that restructures your entire perspective. Remain with me through every single point. First, understanding what these 3 medications actually accomplish and why they're absolutely not interchangeable variants. Amlodipine, Losartan, and Lisinopril all decrease blood pressure, yet they accomplish this by working within 3 entirely separate bodily mechanisms. Those distinct mechanisms generate entirely different responses, entirely different dangers, and entirely different warning indicators requiring your attention. Misunderstanding which system your medication influences means misinterpreting signals from your own body. Amlodipine functions as a calcium channel blocker. Visualize muscular tissue surrounding your blood vessels. That muscle contracts and relaxes based on a single trigger, calcium flowing into muscle tissue. Calcium enters the muscle, contraction happens, vessels tighten, pressure increases. Imagine each muscle cell contains tiny openings permitting calcium entry. Amlodipine reduces how many remain accessible. Diminished calcium entry means diminished muscle tightening. Pressure drops. But understand what this doesn't accomplish. It fails to address why those vessels became rigid initially. It manages output. It doesn't restore the system creating output. Lisinopril functions as an ACE inhibitor. Your body generates a substance termed angiotensin II that narrows blood vessels and directs your kidneys toward fluid retention. Manufacturing this requires an enzyme designated ACE. Lisinopril prevents this enzyme function. Imagine halting an assembly line that manufactures the narrowing substance. No manufacturing, no substance, lower pressure. Additionally, because it decreases kidney workload, Lisinopril frequently represents the initial selection for older patients managing simultaneous blood pressure and emerging kidney issues. Losartan works as an angiotensin receptor blocker. It targets the identical system as Lisinopril, but intervenes at a distinct location. Lisinopril prevents angiotensin II production. Losartan lets production continue but blocks the receptor where the chemical must attach to tighten vessels. The signal transmits. The target is blocked. The message doesn't transmit. The practical distinction between both comes down to one adverse consequence. Lisinopril produces a relentless dry cough in numerous patients. Losartan doesn't. Physicians don't substitute one because the alternative is inferior. They substitute because nighttime coughing every single night for months represents suffering that a straightforward medication change eliminates. Second, comprehending amlodipine swelling and why Ellen nearly surrendered her existence over it. This is the discussion Ellen should have had many months before her son contacted my office. Amlodipine relaxes the microscopic veins in your lower extremities more intensely than it relaxes comparable arteries. Blood circulates down into lower areas without difficulty, yet struggles traveling backward and outward. Fluid escapes vessel walls into surrounding tissue. That explains why footwear fits fine at dawn, yet feels uncomfortable by evening. That explains why swelling disappears throughout nighttime and returns predictably the next day. This carries no connection to cardiac failure or kidney complications. It represents the expected mechanical response to how this specific medication category affects lower body circulation. However, Ellen's genuine danger stemmed not from swelling itself, but from secrecy. She feared her heart was stopping. She began avoiding doses before leaving home because she felt embarrassment about her leg appearance in public. Her pressure rose unmonitored for 5 months. Communicate swelling to your physician without delay. Don't conceal it. Don't self-manage through medication avoidance. Skipping your medication creates substantially greater danger than any swelling. Third, comprehending the lisinopril cough and recognizing which symptom requires immediate attention. Do you consume lisinopril? Answer sincerely. Have you developed a cough since initiating it? Not a productive cough with mucus, a dry, scratchy, persistent cough that nothing relieves. The complexity here lies in timing. The cough doesn't always appear immediately. In certain patients, it emerges 3 months later, 6 months, even longer. By that point, your connection between cough and medication has completely vanished. You attribute it to seasonal triggers. You suspect gastric reflux. You experiment with different toothpastes and purchase lozenges and adjust your sleeping arrangement. Michael turned 71. 5 months following Lisinopril initiation, he experienced a throat irritation that persisted. He purchased a costly air filtration system, switched laundry products twice, and propped himself on 4 pillows nightly. When I questioned whether the cough coincided with medication initiation, the space became silent. Nobody had clarified that lisinopril cough can surface late and persist indefinitely. The cough itself creates discomfort without danger. Communicate it. Your physician can transition to Losartan, and the cough typically vanishes within 14 days. However, one symptom accompanying ACE inhibitors demands emergency intervention: inflammation of lips, tongue, facial tissue, or throat region, particularly when swallowing or respiration becomes difficult. That condition is angioedema. Though uncommon, it becomes critical within moments. Persistent dry cough, report at subsequent appointment. Throat or facial inflammation, activate emergency response immediately. Fourth, understanding timing errors that gradually diminish medication effectiveness. Your blood pressure fluctuates throughout each day. It follows a consistent pattern. It climbs sharply during early morning hours, reaches maximum mid-morning, decreases afternoon, and reaches minimal levels during restful sleep. Your physiology creates this rhythm daily, regardless of consciousness. Timing determines when your medication performs maximally and when it weakens. Amlodipine demonstrates extended persistence in circulation, so timing flexibility is greater. However, Losartan and Lisinopril summit within particular timeframes following ingestion. If your most dangerous pressure increases happen early morning, yet you consume medication at midday, you're leaving your most vulnerable period undefended. Patricia was 68. She consumed Losartan every afternoon at lunchtime because remembering medication at that moment was easiest. Her morning readings constantly exceeded acceptable levels, and she assumed the drug had become ineffective. It hadn't. It was performing maximum effectiveness at 4 in the afternoon when her numbers naturally declined anyway. We shifted her dosing to bedtime. Within 3 weeks, morning measurements normalized without medication adjustments or dosage modifications. Discuss with your physician whether your particular medication should be ingested morning or evening. That single conversation potentially transforms your every measurement. Fifth, understanding the potassium hazard existing outside your medicine cabinet. Go to your kitchen storage immediately. Examine your salt container and seasonings area. If you're taking Losartan or Lisinopril, items present there likely introduce potassium into a system your medication already preserves. Losartan and Lisinopril can elevate potassium concentration in circulation. Excessive potassium disrupts electrical impulses, maintaining regular heartbeat. Manifestations are frustratingly unclear. Muscle fatigue, unusual heaviness in limbs, periodic heart irregularities, sometimes nothing whatsoever until becoming dangerous. Heart-healthy salt alternatives substitute potassium chloride for sodium. Hydration supplement powders contain concentrated potassium. Senior-specific meal replacement beverages frequently incorporate potassium additions. Each quietly adds potassium into circulation, already retaining excess. Robert was 80. His spouse convinced him switching to potassium-based salt alternatives supported cardiac wellness. He'd been consuming Losartan for 2 years. Nobody connected those circumstances. He felt progressively weaker. Standard laboratory results revealed potassium levels warranting immediate intervention. Robert wasn't negligent. He wasn't careless. The information simply hadn't been provided. Examine every label on kitchen products claiming cardiac advantage. Ask your physician directly. Given my specific medications, can I safely utilize potassium-based salt options? Sixth, understanding the painkiller inside your bathroom storage right now. Check your medicine cabinet before this finishes. Search for ibuprofen or naproxen. If you use Losartan or Lisinopril, particularly alongside diuretics, frequent consumption of these common pain relievers can restrict blood supply to your kidneys and elevate kidney damage likelihood. Not because individual medications are hazardous alone, but because combined inside a potentially dehydrated physiology, they create situations your kidneys can't easily manage. This receives no attention during standard visits because ibuprofen seems like convenience store medication. It's not prescription. It doesn't feel like serious treatment. Therefore, discussion never occurs. Charlotte was 75. She consumed naproxen twice daily, managing knee arthritis discomfort. She'd been taking lisinopril across 4 years and a reduced-dose diuretic across 2. Her annual physical revealed quietly decreasing kidney performance markers. Not drastically, but sufficiently, her physician immediately stopped naproxen and arranged comprehensive testing. The combination had taxed her kidneys monthly without any noticeable sensation. Request this from your pharmacist specifically. Given everything I'm currently taking, can I safely use ibuprofen or naproxen regularly? That conversation requires 5 minutes. It costs nothing. It might prevent complications nobody anticipates because nobody considers raising the question. Seventh, understanding medication behavior during fluid depletion. If you consume Losartan or Lisinopril and become significantly ill, intense vomiting, severe diarrhea, fever-producing sweating, medication functioning perfectly yesterday may behave very differently today. These medications are calibrated for physiologies with consistent fluid equilibrium. When illness eliminates that equilibrium, your usual dose may now lower blood pressure excessively and stress your kidneys. The medication didn't become harmful. Your physiology fundamentally shifted. Kenneth was 73. A viral infection incapacitated him throughout 2 days. Maintaining hydration proved nearly impossible, yet he consumed his Losartan every morning without interruption because maintaining perfect consistency through 16 months represented personal pride. That evening, rising from his sofa caused his legs to collapse. His blood pressure had declined so substantially, his body couldn't compensate quickly. The medication wasn't problematic. His physiology was depleted, and nobody warned him to pause and consult his physician first. Write this and post it visibly for illness periods. If I cannot retain fluids for exceeding 12 hours, I contact my physician before consuming my next pressure medication. That singular statement could prevent emergency situations. Eighth, recognizing that blood pressure numbers can deceive. Your most alarming reading may not represent your most dangerous condition. It might simply be the one obtained incorrectly during stress instead of calm assessment. Pressure shifts constantly. Anxiety elevates it. Caffeinated beverages elevate it. Sleep deprivation elevates it. Even the worry about what your measurement might reveal can artificially increase it. Readings captured while rushing, following conflict, after anxiety can differ significantly from those obtained while seated peacefully for 5 minutes with feet resting and arm positioned at heart height. One measurement is meaningless noise. Multiple measurements create legitimate information. Only genuine information justifies decisions. Karen kept extensive blood pressure documentation. Page after page, she measured constantly during dizziness, during tension, continuously reading medical content. Her log displayed chaotic information, numbers fluctuating dramatically between concerning and normal with zero consistency. She believed her Lisinopril wasn't functioning. Reviewing her measuring technique revealed completely different information. She was measuring different arms at different moments, directly succeeding stressful situations. When we standardized technique, identical arm, identical chair, consistent restful time, consistent morning measurement, completely different data emerged. Her medication was performing correctly. The inconsistency was methodology. Measure identically every day. Identical arm, identical seating, 5 minutes, peaceful rest. Document every measurement. Interpret patterns across weekly measurement, not isolated snapshots. One measurement is a single instant. Weekly measurements reveal genuine narrative. Only genuine narrative conveys factual information. Ninth, and this restructures everything. Throughout 28 years, managing cardiology patients and thousands of medication prescriptions, the single most essential truth about these 3 medications represents something virtually never articulated when physicians write prescriptions. These medications don't eliminate the condition producing elevated blood pressure. Amlodipine decreases vessel wall contractility, yet doesn't undo decades of accumulated stiffness. Lisinopril deactivates the enzyme producing tightening signals, yet doesn't reverse cardiovascular shifts that intensified signal frequency initially. Losartan blocks signal docking sites, though signals continue manufacturing and transmitting constantly. All 3 manage what systems produce. They don't restore the actual generating system. This explains why subsequent appointments matter beyond initial prescriptions. This explains why reducing sodium consumption, enhancing sleep, maintaining movement, and managing weight aren't supplementary recommendations. They constitute treatment itself. Your medication and daily behaviors don't address separate concerns. They address identical concerns from divergent approaches. Synchronized, results improve steadily. Conflicting, dosages increase, adverse reactions multiply, and medication requires escalating strength, simply maintaining previous effectiveness from months earlier. I've encountered identical patients, matching medications, matching dosages, matching ages, demonstrating completely different outcomes. The difference was never the medication. It involved the physiology the medication influenced. Consistently high-performing patients across 28 years aren't those requiring maximum medications. They're those comprehending what their medication accomplishes and equally significantly what it doesn't. They selected intelligent collaboration. Let me describe Ellen's outcome. Following her son's phone conversation, I scheduled Ellen not for record examination, but for genuine conversation. We sat alongside each other rather than across a desk. I clarified everything I've just communicated. I described her ankle swelling mechanism. I confirmed cardiac failure wasn't developing. I emphasized dose skipping presented greater danger. We modified treatment. We examined kitchen products comprehensively. We established measurement methodology she could depend upon. Within 4 weeks, swelling was controlled. Blood pressure stabilized. Ellen participated in the community literacy program every Tuesday afternoon, finally wearing genuine shoes after months restricted to slippers. During her subsequent appointment, Ellen expressed something I haven't forgotten. She said, "Dr. Lee, I invested 5 months mentally preparing for death from something carrying a straightforward explanation. I simply required someone describing it clearly." 3 months afterward, Ellen duplicated a single-page summary of everything we discussed. She distributed it to 14 people in her reading association. 4 formulated inquiries for their physicians previously unconsidered. 2 received medication adjustments. 1 had managed Lisinopril-related cough across 1 year, attributing it to home heating systems. The information existed. The remedy existed. The conversation simply hadn't transpired. That purpose drives this channel. Following 28 years in cardiac medicine, one certainty exists. Seniors successfully managing blood pressure aren't those consuming maximum medications. They're those comprehending actual physiological processes, utilizing that comprehension toward improved decisions daily. Ellen required no medication adjustment. She required explanation. Michael required no suffering through persistent coughing. He required 1 inquiry answered. Robert required no dietary restrictions. He required understanding what already inhabited his kitchen. Karen required no panic regarding measurements. She required dependable methodology. Information isn't peripheral. Information is the treatment itself. Now I want something from you. Which medication among these 3 do you currently consume? Amlodipine, Losartan, or Lisinopril? Write the name in the comments. That singular word demonstrates what you prioritize and guides what I address subsequently. Before consuming tomorrow's medication, hold this question. Do I genuinely comprehend what my medication currently accomplishes physiologically and what it isn't accomplishing? If your answer isn't thoroughly affirmative, that's not your responsibility. That gap represents exactly why this channel operates. I'm Dr. William Lee. Subscribe to ensure you never miss the guidance your wellness deserves before emergencies you didn't anticipate develop. See you next week.